So yeah, so basics of digital pathology. So one step back, what is it that you need to get a scanner in your lab? What all do you need to look for? What all factors come inside when you're deciding which scanner to go with and what to do? So what is digital pathology? Basically, it is digitization of a glass slide, creating high resolution images, which can then be used for either telepathology, reporting on a screen, or running your AI algorithms, right? So 10 questions to ask yourself before deciding to buy a scanner. So my journey with digital pathology started in 2018, where in Tata, Kolkata, we got our first scanner under a grant, and that was a very eye-opening experience because that was a completely, you had to select the areas manually, put the focus points manually. And then the moment I joined the lab in 2019, the first aim was to get a scanner here. So like Madam said, buying a scanner on your own in a standalone laboratory is not easy. But there are ways around it. If you have a good idea, you can write up a proposal to BIRAC, get a grant. At that point of time, you get funding. That is a way you can get a scanner in-house. Many institutes have worked with different IT institutes and tried to get scanners in-house. So these are ways by which you can get a scanner even without spending a lot of money directly from your pocket. But you need to have a good idea for that. So what is your budget and what is your throughput? First thing, throughput is defined by what do you need to use the scanner for. Are you using it for your daily reporting? Or are you using it only to share cases when the time comes? So if you needed to share cases, then a slide scanner, a single slide scanner, or a 6-slide scanner is also more than enough. But if you want to digitize your entire daily workload, then that depends on how many slides you have. 200 slides per day, 300 slides per day, then you need scanners of that scale. Then comes in the question about budget, right? Your throughput is always, your budget and throughput have to go hand in hand. You might want a 200-slide scanner, but you don't have the budget for it. So that's why budget and throughput go hand in hand. Decide your throughput and then decide on the budget. What do you want to use it for? Bright field, immunofluorescence, or right now you want to use it for bright field and in the future you want to upgrade. This is something you need to look at. Check the demand outside your department. Like see, in big institutes where you have like a department of oncopathology, department of dermatopathology, so one department wants a scanner, and then everybody else around them also starts wanting that scanner. So your throughput has to be calculated based on your predicted requirement of your hospital or the entire pathology department as a whole. Then space requirements, right? You can't just, a scanner does not have a very large footprint. It can be put on any regular table, but it does need a vibration-free table. It comes with a lot of other equipment, like you get a CPU with it, you get a server with it, you get a monitor, mouse, you need place to sit and actually load the slides, scan them, store the slides. You also need a decent level of IT infrastructure. These days, all you need is a fast internet connection, but that also has to be there. So you need to create a small space in your lab where that can be put. Keep it away from places which produce micro dust particles. For example, your sectioning room where there is wax in the air, things like that, you need to keep it away from that. Then what size slides do you scan? The standard size is what, 3 inches by 1 inch. But are you dealing with larger slides? For example, in ophthalmology, pathology, you have large sections, right? You need to find out if your scanner is capable of scanning those, if you're dealing with that kind of work. What magnification and focus do you need, right? So 40x is what we all need. Some cases we need 100x. If you want to scan bone marrows, then you might want 100x. So there are scanners which are capable of doing oil immersion scanning also. Then are you working with a lot of cytology specimens? Then if you're working with cytology specimens, you need something called as, okay, so when we look at cytology, what is the first thing that we do? We focus, and then we go into the fine adjustment, right? So fine adjustment in terms of scanning is called as Z-stacking. Z-stacking is basically at one particular focal point, it's going to scan multiple levels. So that gives you the feel of a fine adjustment in your microscope, which is useful again if you want to do that kind of work. What additional equipment is included with the scanner? There's a slide viewer, which is a software, a high-resolution monitor, mouse, keyboard, a storage server. This is very important because you can't keep storing on the cloud because cloud adds extra cost. Image management systems. So be sure to compare different slide viewers and image management systems in advance. Right, so for example, creating a storage server. So each scanner will come with a server that has got a basic data capacity. Like it can store maybe 500 scans or 1,000 scans or 2,000 scans. You need to work closely with your vendor to figure out a way to increase that capacity without adding cost. So for example, in the lab, we have converted our server itself into a cloud server. So it has got a static IP by which I can access it from anywhere. Then once our data got filled, we added an extra hard drive, another 4 terabyte hard drive, so that added huge storage space for us at no extra cost except for the cost of the hard drive. So these are things which you can do if you have little bit of technical knowledge, very little. Right, then how do you want to interact with the scanner? Do you want it to be completely automatic, where you load 200 slides in it and you just walk away? It selects the area, it maps the focal points, and then it does the focus points, and then it does the scanning. Here the advantage is it's a walk-away system, less manpower intervention. Disadvantage is lightly stained, small particles which are there at the periphery of your section might be missed. Then you've got a semi-automatic mode where you select the area to scan, and then you walk away, like load 6 slides or 10 slides, select the areas, and then the scanner does the rest. Then you have a single slide scanner where you scan one slide at a time. So say there is a slide which is very difficult to scan, right? So then you can add more focus points on that particular area which is becoming difficult to scan. So this would be the most accurate, but the fastest would be the first option. How easy is it to scan the slides, right? So a pathologist is not going to do this work, and you're definitely maybe not going to hire an IT professional to do this work. You will need somebody like a BSc MLT person or an MSc person to do the scanning. So it has to be the software has to be intuitive, like it has to be easy to use. The number of steps to start a scan has to reduce. So all this matters. How does it integrate with the other systems in your lab? Right. So a scanner by itself is just a way to view the slide. Where the actual use of it comes in is how does it integrate with your LIS. For example, when you start reporting a case, what all data can it pull from your LIS, from your from the hospital or HIS, that is your hospital information system, onto your screen, which will enable you to give a better diagnosis. So ensure that the scanner integrates well with that. Find out what format of image is produced by the scanner. There are some scanners which produce very proprietary images. Like for example, there are some formats which cannot be read by any other viewer, so that time you become dependent on that particular vendor. This will in turn limit the use of the different types of AI algorithms that you could be using on that particular image, right? So that is something you need to discuss with with the different vendors. All right, and then are there anything extras included in the package? Like how Madam was just telling us, they wanted to scan slides, view slides, but telepathology software was not provided, right? So that is an issue which we faced previously also. So the scanner costs like say X amount, and the software costs somewhere close to the X amount only when you're using some brands. But these days it comes as a package. Like as we say, once it entered the mass market where a lot of people started buying scanners, then all these things came up. Telepathology capabilities, virtual slide conferences, slide annotation capabilities, the ability to download your slide. Like as in, you don't need to be dependent on their viewer only. You can download the slide in a TIFF format and then utilize it for different purposes. So all these things need to be discussed. Simultaneous viewing of multiple slides, this is something I found very useful. So say you're diagnosing Hodgkin's lymphoma, you need to look at that RS cell, and then you need to look at the different stains on that particular RS cells. How do we do it now? We look at that area, we mark it, and then we keep changing the slides, right? Instead of that, you open all your 6 slides at once, the scanner maps the points, and then it focuses, and when you move one slide, all 6 move together. So that way you can view all your stains on that particular slide at the same time. AI algorithms, are there any AI algorithms that come with the application or with the software itself? Many people are launching your ERPR, HER2 algorithms inbuilt with the scanner. KI is becoming very popular. So that is something else that you need to discuss. Right, so how do you evaluate image quality in digital pathology? Okay, so image quality, the simplest way is, this is my microscope, this is what it looks like, the screen has to look the same, right? That is how I looked at it when I first decided, okay, I should go for a scanner. And then Dr. Tapadia gave me a paper which he asked me to go through, where it said that, okay, these are the technical things that I need to look into. So I'm just going to present 2 or 3 of those here, which you can ask your vendors, so that your comparison has to be objective. It can't just be subjective. One person's ideal quality may not be another person's ideal quality, right? So image quality basically is the fundamental aspect of any scanner. It will determine your diagnostic accuracy, reproducibility, and reliability of your various AI algorithms. We'll focus on 2 aspects of this. One is called image resolution, and the other one is color fidelity. Image resolution. So what is image resolution? Basically, you have 2 lines which are placed very close together, right? Okay, these are 2 separate lines. A scanner which has got a very good resolution will be able to make out that these are 2 separate lines. But a scanner which has got a poor resolution, for that it will appear as a single line. So that is what image resolution basically means. That is the ability to visualize the smallest structure in a cell. Nucleolus, the chromatin, so that. So it is a key indicator of image quality. It determines the clarity of your image to see nuclei, nucleoli, chromatin patterns. High resolution images will help you diagnose better. Low resolution images will lead to blurred nuclear details, blurred chromatin features, which will again hamper your diagnosis. Right. Then there is a concept in image resolution of magnification. Magnification in a scanner is very different from magnification using a lens, right? Many scanners have got a 20x lens, but they produce 40x images, and they also have a digital zoom going up to 80x. So how does that work? So in your eye, your optical resolution of the retina is fixed based on your the cone cell spacing. So then anytime you need to magnify something, you need to change your the objective lens. I mean, you need to go from 10x to 20 to 40. Whereas in a scanner, there are multiple components over there. First, you've got the light source, then you've got the optical part of it, which is a lens, then you've got a camera sensor, and then you have a software in the middle, and then you have the monitor, right? So when you have a lens which has got a higher numerical aperture, or a scanner which is, or a camera which has got more pixels in it, you can capture a better, higher quality image. That means using a 20x lens, you can produce a 40x image. Okay, this is a very busy slide. It's just to highlight what all goes into it. Like there's an optical resolution, image resolution, display resolution. All these factors match into your final image clarity. Look into the numerical aperture of your lens. The lenses that are used in the scanner have got a higher numerical aperture. Second thing you need to ask them is, what are the microns per pixel? For example, for a good 20x image, you need to have less than or equal to 0.5 microns per pixel. And for a good 40x image, it is less than or equal to 0.25 microns per pixel. This is what you need to ask them, like how many pixels per micron? Sorry, how many microns per pixel? Right, then you've got color representation, right? So histopathology is all about colors. Faded slides are difficult to diagnose. Dark staining slides are again difficult to diagnose. So this becomes a very important aspect of it. So ideally, digital images should closely match the visual experience under an optical microscope. Color fidelity basically means the ability for the scanner to reproduce the color which is there on your regular HND slide when you see it through your microscope. Color distortion may lead to incorrect interpretation, especially in immunohistochemistry and special stains. So changes in color reproduction, there are multiple factors. First is the device-related factors, and the second one is your lab factors. Device-related factors means the cameras, sensors may be different, the objective lens may be different, so sometimes there's variation even between two scanners, right? And the environment in which you're scanning, is there a lot of external light that is coming in? All those also factor in, which come under your device-related factors. Then your sample preparation variability. This, I think all of us know. No two HND slides are alike. I mean, on the same day, you can get different stain slides, different batches. Your different technician is staining your slide, different technician is cutting your slide. All those things come into the picture here, right? So all these things ultimately lead to your image thing. So color calibration, just like, okay, I'll just summarize this. How in biochemistry we have a calibration, like 1 is equal to 1 and the machine is supposed to measure that. Calibrations are also available for different scanners, where the entire spectrum of colors that is there in an HND slide is fed into the scanner and says that, okay, this color is equal to this. So that is how you calibrate your scanner. So most of the scanners these days auto-calibrate, and that's how you get your image clarity. So when you scan images continuously and you see that, okay, it's fading out a little bit, at that point of time, you need to recalibrate it, or you talk to your service provider. So comprehensive image clarity, field uniformity, that means less than 5% variation in brightness and focus. Image stitching quality is very important. Sometimes scanners show boxes in your images. There are multiple boxes. Sometimes these boxes are called tiles, right? So a scanner basically has got a camera which clicks multiple images which are stitched together. So if the stitching is not proper, you'll be able to see those individual images. If an image goes missing from there, you have missing data. So these kind of things need to be looked at. Storage and transmission efficiency, balancing compression and transmission becomes important. Then comes the most important, one of the important factors is validation. So you need to validate at least 60 cases of HND plus another 20 cases of any other stain or IHC stain that you're using. Pathologist has to get more than or equal to 95% accuracy when he's diagnosing these cases on the microscope and on the digital scanner, and there has to be a washout period of at least 2 weeks between them. So these are CAP guidelines available on their website. Right. So now we come down to 15 questions that matter. So it's a summary of whatever we've discussed. What is a scanner sustained daily throughput? Everyone says our scanner can scan a slide in 2 minutes. But that 2 minutes is like your ideal scanning. It's like your car ka mileage. 20 kilometers per liter, that is on the highway without braking and everything. But on regular road, what is your actual throughput? That becomes important. How consistent is the focus across uneven or thick sections? So cytology, bone marrows, decal sections, this becomes very important. Fully automated or semi-automated system, this determines what level of technicians you need to handle that particular scanner. How often does the scanner require manual intervention? Like, does it jam, or are there multiple prompts coming up on the screen which stop the scanning? This will determine whether you're able to do an overnight scanning, or you can do it, or you need to do it only during the day. How reliable is color reproduction? I've gone into detail on this. What is the maximum slide capacity per batch? Is it like 80 slides, 100 slides? That is directly determined by the type of scanner you purchase. Is there a stat mode in the scanner? That's also an important factor. Like once scanning starts up, do you have a stat mode where there's an emergency slide which needs to be scanned or a frozen slide which needs to be scanned? How does the scanner handle barcode reading? When you're automating your entire lab, barcode reading becomes very important. So these are multiple aspects which were there in all the other departments, which have now become very important pathology when you decide to go for a completely digital pathology workflow. What compression file formats do you use? I've already told you, proprietary formats make it very difficult for you to utilize those images for other purposes. How well does the scanner software integrate with the existing system? I'll just go into that towards the end of the presentation. What is included in the scanner price? There's also CMC, AMC, your telepathology software. All that also comes in when you're buying a scanner. It's not just like you're purchasing a camera. You need to find out everything else about it before deciding. How scalable is the platform as slide volume grows? Like you can add more scanners to it, or is your software or the server capable of handling more slides? That becomes important. Is the scanner validated and suitable for clinical diagnostic use? Another important factor. What is the uptime, right? So a high throughput, like a 1 minute scan time or 2 minute scan time means nothing if the scanner keeps breaking down, right? If you have multiple breakdowns, then it defeats the whole purpose of having a high throughput scanner. Is the scanner designed to support AI algorithm and AI workflow? So you need to discuss with your software provider if AI algorithms can be integrated into your routine workflow, or how easy is it for that to happen. So they should be willing to help you with all that. Right, because the scanner is there, the software is theirs. They need to open the code, or they need to push data from there into your AI pipeline. So you need to figure out if they're willing to do that. Big companies, you know the hierarchy. Smaller companies, it's easier. But then technical support of bigger companies, smaller, you need to weigh all those factors in. And then obviously find out from the customers, like how is the scanner, what is the support like, what is the breakdown time, right? So this was all about the scanner. Now there is a concept here which is basically implementing the entire digital pathology workflow. So digital pathology does not just mean that you buy a scanner. It means you digitize your entire histopathology workflow. You bring in additional information which helps you make a diagnosis, right? So it is an integrated approach to the entire histopathology lab to go to a truly paperless laboratory, right? So it is an integrative approach which includes your photography, digital pathology, grossing photographs, section photographs, pulling in data from your LIS software. It requires, why is this happening? Because the number of skilled technicians is reducing, skilled pathologists are reducing. So at that point of time, and your AI workflow is increasing, right? So AI is only as good as the data that you give it. You give it only images, it can give you reports on only images, but you've given a lot of clinical data to it, then it will obviously give you a far better report. Collaboration for this requires multiple departments, like you need your IT department, pathologists, administrative personnel, histotechnologists. Everyone has to be on board for this particular transformation of your lab. So first is the physical layout restructuring. Optimize the workflow in such a way that there is no crossover between your technicians. This basically becomes easy. Like there's a workflow where the grossing, then it goes for processing, then it goes towards embedding, and then for the rest of the process. Strategic instrument placement. For example, the cover slipper can be next to the stainer. The scanner can be next to the cover slipper. So that basically improves your lab's workflow. Standardizing pre-scan quality is very important because the scanner is only as good as a slide that you give it, which basically means that the slide has to have a uniformly thin section. It has to be bubble-free. DPX has to be at the same level. So role of LIS and informatics resources. There's unified tracking. That means okay, so basically it means that each specimen comes with a barcode. You scan that barcode. That barcode is linked to your hospital's HIS. It pulls in all the information from there, pulls in what all tests have been ordered for that particular patient. Then that barcode, based on that barcode, a histopathology number is assigned, and then based on the histopathology number, numbers are assigned for all the blocks and the slides that come out of it. So there is a continuous LIS tracking, which enables you to identify any slide faster, and it also prevents mismatch. Now your pathologist cockpit, basically, it's not just one screen, it's two screens. One screen which shows you all the information, gross photographs, LIS information, clinical history, everything. And the other one is your actual whole slide image where you can view and decide and type out your report. Software has to be willing to integrate with other softwares. That is the most important factor. You cannot have a closed box. If you have a closed box, you're dependent on that one vendor for everything, which again leads to problems. It will lead to technological slowdown of your lab, and then every single integration will mean that you have to change something or the other, and cost gets added to it. So, okay, we'll go into step-by-step process. So, accessioning control, like I said, sample requisition is entered in your HIS or LIS itself. When it comes to your department, the requisition form has a barcode. You scan the barcode. The container has a barcode. You scan the barcode. All the information comes in. What are the tests that have been ordered? What is the procedure that has been done? The radiology information. Everything is available to you. Then in grossing, you can do an automated grossing where you can use a speech-to-text software, or you can simply make your typist sit in the grossing room and type out the grossing as you're dictating it. While he's doing that, he will also enter the sections in the software. He'll also enter the blocks in the software. So you know that how many blocks have been given, how many sections. So all this is being done manually right now. All of us do it manually, right? We have registers to do all this. We are just saying that, okay, let's digitize it. Taking a photograph of the gross image, again, is very important. Right now, you take a photograph, your colleague or your resident sends it to you, or Satish sir has that innovative idea where everything is stored in one Google Drive and anyone can access it from there. But that becomes difficult, right? You still have to go to it and see it. So for a gallbladder, for example, or for an appendix, you might not want to see that image. But imagine if it was displayed on its own. Wouldn't that make your job easier? Because we always say, start with the gross, then go to microscopy, right? Then taking a picture of all the sections that you've given with the color and the orientation, inking and all that, that again becomes important. So all this can be done and fed into your LIS. Embedding station. So then it goes to the processor, right? In the processor, again, when the blocks are being loaded, scan all the the blocks are labeled with barcodes, scan the barcodes. You know which block is going into which processor in what time schedule. Then it goes to the embedding room, again the same process. Take a photo, the barcode is scanned, you know which slide is being, which tissue is being embedded. You take a photo of the photograph of the sections. While you were grossing, comes up on the screen, you know how to embed, your technician knows how to embed that particular section properly. Again, the sectioning station, as you're scanning the barcode on the block, it prints out the slide label, and then it makes the entire process very streamlined over there. Then you also take a section of the face of the block, right? The cutting surface of the block. How much tissue is there, how much tissue is left over, or are you missing out any smaller bits? So that again becomes important. Then staining and mounting, again, this is very common. Most labs have automated stainers and cover slippers now. Then you come down to the scanner. So do you go with a single large scanner, but if it breaks down, your entire workflow gets stuck? Go with 2 or 3 medium throughput scanners, which can be faster, and even if one breaks down, you have the other one available. Daytime scanning protocol, right? So many people follow this nighttime scanning, just load it and walk away. That is good, but if it jams at night, then your entire workflow is stuck. So they advise do a daytime scanning protocol. But then that is, again, depends on your individual experience. So this is the clinical validation. We've done this. Assuring scan quality. Before the scan is given to a pathologist, you can have a histotechnician look at it to see if it's focused properly. Or you also have AI softwares to determine the quality of the slide that you have prepared. Only if the slide quality is good, that means the focus is even, staining is good, then it should be pushed to the pathologist. Verifying tissue coverage. This becomes important. For example, in this particular bit which you're seeing over there, a small bit is there at the periphery of the section. That might be missed when you're doing an completely automated scanning, right? But this image which you're seeing, the picture-in-picture image, that is actually a macroscopic photo of your slide. So you can see that and decide whether everything is there or not there. And what you see here is basically like, it shows you how much of area have you scanned. When you have a microscope, right, you have a box, you can draw a box around your section and go in a zigzag manner. But in a scanner, it's not possible. So here, it shows you what all areas you've screened, and so what is missing can be screened again. Data storage, I don't know if NABL has given any guidelines for how many years the data has to be stored. So this article suggested that 10 years, 10 years is what they've suggested, but.
NABL suggests right now, not on the.
Yeah, so.
It's about our
But then the point is you have to factor in that you need to store data for 10 years or 15 years. Workflow is right now this much, workflow may increase to this much, figure out your storage accordingly. Storage becomes expensive once you have to scale to those many number of slides. Right, so this is the entire workflow, and we figured out all the steps where you can add in automation. So finally, you get all the information on your screen. For example, you will get your gross image, you will get the sections that were given, you will get all the clinical data, you will also get the surface of the block. All the things which you would want to do if you were reporting in an ideal situation. Suppose I give you time and you have only one case to report in the entire day. You will definitely go and look at the gross image, you will look at the sections, you will see the block surface. Finally, you will give an accurate report. Suppose we give you all that information on one screen. It's not like we don't want to see the information, it's just that we don't have the time to see it for every single section. But if it's provided to us, then it obviously improves our accuracy. Second thing is, all that information with your slide and the diagnosis can be fed into an AI engine. And you will definitely be able to come up with far better conclusions than with a digital pathology image alone. Right, so last I have just 2 slides to touch on something called as slide-free microscopy. So this is something which is becoming popular, and this is the new technology that is coming up. So basically in histopathology, everything depends on your glass slide. Glass slide, to prepare a glass slide, what all does it take? First section comes, fixation, grossing, processing, and finally. So roughly around 24 to 72 hours to get a slide, depending on the size of the tissue. A novel approach will eliminate the entire bottleneck process, that is the processing part of your histopathology lab. So here basically an intact tissue is taken, a small section from that is taken, or the intact tissue is put into a specialized scanner. You can call it as a scanner, but these scanners may be based on UV light, or they may be based on different other technologies. And finally, you get an output which is equivalent to your HND image. For example, one of the technologies uses ultraviolet imaging to excite the cells. Each cell has got different features in it. Like for example, nucleus has got different excitation, cytoplasm has got different excitation, right? So you have a scanner which captures all that. You have a camera which captures all that, converts it to a digital image, which you can then view. So which means the entire process is finished in about 10 to 15 minutes, and your tissue is still intact. So these are the things which are coming up. This is the advantage of it. It narrows it down to about 10 to 15 minutes, makes it possible to utilize it in areas where histopathology labs are not well equipped to produce thin, proper sections. New technology, but this is what I could find. I've not gone through each of them. I've explored 1 or 2 options, like I've just read about them. But this is something, if you have a lab where there are regular frozens happening, it can be something which is worth exploring. The technology is out there. We just need to decide if you want to bring it here or no. So these are my references. And yeah, thank you so much.